The following podcast is part of a certified educational activity titled Progressing PrEP, Latest PrEP Advances to Prevent HIV Transmissions. Access the entire activity and complete the post-test at peerview.com/NQE860. Downloadable slides and practice aids are also available.
Hello, my name is Colleen Kelly. I'm professor of medicine in the Division of Infectious Diseases at Emory University School of Medicine in Atlanta, Georgia. I'm also co-director for our Center for AIDS Research. And so this talk is Progressing PrEP, Latest PrEP Advances to Prevent HIV Transmissions. So our goals for today are as follows. We'd like to augment your knowledge of long-acting injectable PrEP efficacy and safety. We'd like to equip you with strategies to help patients choose the most suitable PrEP formulation for their needs. And finally, provide some guidance on how to implement new advances in PrEP into your clinical practice. And so let's get started with an overview of the different types of pre-exposure prophylaxis. So, just to set the basics, what is pre-exposure prophylaxis? This involves regularly taking antiretroviral medications before a potential exposure to HIV in order to lower the risk of HIV acquisition through sex or injection drug use. CDC advises that all sexually active adults and adolescents should be informed about PrEP and given the option to take PrEP if they choose. This is particularly important for those who've had a recent history of sexually transmitted infections, those who don't consistently use condoms with partners of unknown HIV status, and those who may have a partner living with HIV without an undetectable viral load. When taken as directed, PrEP is approximately 99% effective in reducing the risk of acquiring HIV through sex. So it's a really important intervention. Currently, PrEP is available as a daily pill or in some instances as an on-demand option or 211 PrEP, and it's also available as a long-acting injectable. And we'll review in more detail each of these modalities in this presentation today. So CDC, USPSTF, and DHHS all support pre-exposure prophylaxis. And as I mentioned before, it's really important that all sexually active adults and adolescents should be informed about PrEP and offered PrEP if they choose to take it. The U.S. Preventive Services Task Force, or the USPSTF, strongly recommends PrEP with grade A evidence for people who may be at increased risk of HIV acquisition. And again, the U.S. Department of Health and Human Services, or DHHS, also includes HIV prevention, including PrEP, as one of 4 key strategies in the Ending the HIV Epidemic Strategic Plan. Oral PrEP with FTC TDF, or emtricitabine tenofovir, was approved in 2012, and so we have extensive experience with the use of this agent. So, over the years, in more than a decade since PrEP has been approved or oral PrEP has been approved, uptake has improved significantly, but could definitely be better. The CDC estimates about 1.2 million people in the United States are eligible for PrEP based on risk behaviors. Of those 1.2 million, only about 36% of people who could benefit from PrEP received a prescription in 2022. So while we've done well getting PrEP to some people, we still have a lot further to go. We've also known that significant racial and gender disparities exist in who uses PrEP in the US. If you compare PrEP use versus new HIV cases from 2002, you can see that the new HIV diagnoses far outstrip the number of PrEP users for the Black population, and particularly those people in the southern US, Black people in the southern US, as well as female population, which are underserved with PrEP. So in the southern US in particular, there were 27 white PrEP users for every new HIV diagnosis in a white person. Compare this to among Black people, there were 4 Black PrEP users for every new HIV diagnosis in a Black person. So again, hearkening back to those significant racial and gender disparities that we need to address in order to achieve equity of PrEP use. So this slide reviews current PrEP use in the United States. So again, we have the daily oral options of FTDF and FTAF, or emtricide tenofovir alafenamide. These agents are used only orally. FTDF can be used daily, as well as FTAF. And FTDF can also be used for on demand PrEP dosing in a 2-1-1 schedule. This has been studied, but is not yet FDA approved for those agents. However, it is recommended by the CDC. The current approved injectable option is long acting cabotegravir that's injected every 2 months. Lenacapavir, that we recently had significant positive clinical trial findings that would be injected every 6 months, is set to be reviewed by the FDA in June of this year. In this graph, you can see the significant increases in the total number of PrEP users in the United States through December of 2023, surpassing over 200,000 PrEP users in the country. You can see that the vast majority of those are oral PrEP users, either FTDF or FTAF, with a very small number of injectable cabotegravir users. While that number is increasing, there have been significant barriers to implementing injectable cabotegravir widely, due to insurance approvals and costs, as well as logistics and clinical spaces that have made it a bit more difficult for people to access. So, long acting PrEP is a really important intervention. I've said that it's not widely accessed yet, but it is important for us to think about how we can get more people access to long acting PrEP. Daily oral PrEP is highly effective for preventing HIV acquisition, but its success varies across populations. Long acting populations look to be beneficial for people who experience stigma related to having to take a medication every day, those who may have unexpected or unplanned sexual encounters, those who travel frequently. Time zone changes can be difficult to take a daily oral medication. Challenges with daily pill adherence, including substance use, housing, or mental health disorders, may make it difficult for people to adhere to those daily pills, and where an injectable might be more useful. And also, we've seen if we provide patients with choice, they are more likely to use PrEP. If they have a decision to choose between long acting injectables and oral agents. So, now let's review some emerging clinical trial data on PrEP. And first, starting with long acting injectable PrEP. So, just to review, a few years ago in 2022, we learned the amazing results of the HPTN 083 and 084 trials. These were the trials that compared long acting injectable cabotegravir every 2 months versus daily oral FTDF. Both HPTN 083, which was conducted among 4,566 men who have sex with men and transgender women, as well as HPTN 084, that was conducted among 3,224 cisgender women, showed that long-acting cabotegravir injected twice monthly was superior to daily oral FTDF. In HPTN 083, there were only 7 incident new infections with on-time cabotegravir injections, and this equated to a 66% reduced risk of HIV versus daily oral FTDF. Among cisgender women, there were 0 incident infections with on-time cabotegravir injections, and this equated to an 88% reduction in risk of HIV for cabotegravir versus daily oral FTDF. Long-acting cabotegravir was approved for PrEP in December of 2021 by the Food and Drug Administration. So now let's move to the PURPOSE studies. The PURPOSE studies were reported last year in New England Journal of Medicine, and there were 2 studies, PURPOSE 1 and PURPOSE 2, and we're going to go over each of these briefly because they had some differences in their study designs. PURPOSE 1 was a double-blind, active, controlled, randomized phase 3 trial that was conducted among cisgender women in Uganda and South Africa. Cisgender women who were young, aged 16 to 25, and who were sexually active and not pregnant with an unknown HIV status were enrolled in this clinical trial where they were randomized to receive either injectable lenacapavir every 6 months versus oral FTAF or oral FTDF. Each of these arms had a matching placebo. Because we do not yet have efficacy data for FTAF among cisgender women, that is why there were 3 arms to this study. So it was designed to be the first study to provide efficacy data for FTAF among cisgender women. After efficacy data were released for Purpose 1, participants were able to roll over into an open label extension phase. And in that phase, they were able to opt to continue long-acting lenacapavir injections every 6 months. For those who discontinued lenacapavir, oral FTDF was offered to cover the PK tail phase for 26 weeks. The primary endpoint of these trials was interesting in that it was the first time where a background HIV incidence was calculated, and the primary outcome was the efficacy of lenacapavir compared to the background HIV incidence. This background HIV incidence is what you might estimate would have occurred in a placebo arm. There was no placebo arm in these trials, but the background HIV incidence served as that. Secondary analyses compared lenacapavir to FTDF as well as FTAF, and also examined annual persistence over time. So these are the baseline characteristics in the Purpose 1 study. About 2,000 people were randomized to lenacapavir and FTAF, and about 1,000 were randomized to FTDF. So this was by design. This was a 2-to-1 randomization. You can see that overall, cisgender women in this study were young. They had a fairly high incidence of sexually transmitted infections. What's notable is that very few of these women had ever used PrEP before, less than 10% in any of the arms. And this is really important as we think about choice and expanding access to PrEP. We are reaching people who have never used PrEP before, which is really important. So this were the amazing results of the Purpose 1 study. There were 0 new HIV infections detected in the Purpose 1 study, with over 1,939 years of person follow-up and those who received lenacapavir. Really just astounding results. And now this is in comparison to the HIV background incidence, was estimated at 2.41 per 100 person years. In the FTAF arm, they saw 39 new infections, which equated to an HIV incidence of 2.02 per 100 person years. And in the FTDF arm, they saw 16 new infections, which equated to 1.69 new infections per 100 person years. Overall, FTAF, lenacapavir was superior to both FTAF and to FTDF, which was really important to note. And that there was no difference also when they compared FTAF and FTDF. And we're going to go over that in a bit more detail, but this was really thought to be due to low adherence. So again, there were no new infections in the lenacapavir group. The incident rate ratio with lenacapavir was significantly lower than background incidence as well as FTDF incidence. The incident rate ratio for FTAF was not significantly different from background incidence or when compared head-to-head with FTDF in the Purpose 1 study. So we recently learned at CROI of this year, when we drill down just to efficacy and safety in adolescents, that lenacapavir looks just as good when we limit the analysis to 16 and 17-year-olds. So when you compare in this graph on the left-hand column, 16 and 17-year-olds versus 18 to 25-year-olds, again, this is among cisgender women, we see that there is no increase in study-related adverse events or serious adverse events in the 2 arms. There is also no difference in injection site nodules or pain as reported by age. And this is important to note as being one of the first trials to give us important data in young adolescent cisgender women. There were, again, 0 new infections that occurred in any of the 3 study arms among younger women, lenacapavir, FTAF, or FTDF. And so that's also important to note that no new infections in this really high need group. So when we look at adherence in Purpose 1, we see that adherence to on-time lenacapavir was extremely high. At week 26, it was 91%. At week 52, it was 94%. And that's really incredible to see. It's particularly important when we think about adherence and put that in the context of adherence to oral agents, both FTAF and FTDF. We see on the right-hand side of this graph that over time, FTAF and FTDF adherence waned significantly. The number of people taking with high adherence or taking more than 4 doses a week was low overall in the study and decreased with time. And that's exemplified by the dark shaded bars in both of these graphs. So very few people were actually able to adhere to greater than 4 doses per week of either agent over the duration of the study. So all participants who acquired HIV in the FTDF group actually had low adherence and decreased adherence over time. But when you drill down to just those who were able to adhere and had medium or high adherence, so 2 or 3 doses per week or more than 4 doses a week of FTAP, we did see a lower HIV incidence compared to controls. And that was a reduction of 89% in those who could adhere. So while we did not get the efficacy results that we were hoping for FTAF, in a sub-analysis with only those people who had medium or high adherence, we do see high efficacy in HIV prevention for FTAF with these trial data. And so that's important to note. Now we're going to switch to the Purpose 2 study design, and while it was similar, there are some important differences. So Purpose 2 was also an international double-blind randomized phase 3 trial, and this was in men and gender diverse populations. And so cisgender men, transgender women, transgender men, and gender non-binary people who were sexually active with more than one partner who were assigned male sex at birth were eligible for Purpose 2. Over 3,200 people were enrolled in this study and randomized to either active lenacapavir every 6 months or daily oral FTDF. Again, similar to the Purpose 1 studies, after efficacy was released, participants were able to roll over into the open label extension where they were eligible to choose to get lenacapavir every 6 months. For those who decided to discontinue lenacapavir, they were also offered um, oral FTDF to cover the PK tail phase if HIV risk continued. And so again, similar to Purpose 1, the primary endpoint was comparing the incidence in the lenacapavir arm to background HIV incidence. Secondary key endpoints were HIV incidence while adherence, as well as head-to-head comparison to FTDF. For superiority. It's important to note the difference here from Purpose 1 is that there's no FTAF arm, and that's because we already have good efficacy data for people who are assigned male at birth for FTAF, and so it was not needed in this study. The interim analyses that I will report to you here included HIV incidence versus background, as well as comparison to FTDF. So these are the baseline characteristics. This was a 2-to-1 randomization, 2 to lenacapavir versus 1 to FTDF. So you see about over 2,100 people randomized to lenacapavir and over 1,000 people randomized to FTDF. The majority were non-white race, as well as Hispanic or Latino ethnicity. You can see that over 20% identified as gender diverse, and many people had sexually transmitted infections in this study as well. And so really underlining that the right people who would benefit for PrEP were enrolled in this study. It's important to note that the really remarkable diversity of this trial, of the first time to include all gender diverse populations in an HIV prevention trial, and really succeeding in getting diverse racial and ethnic minorities enrolled. Also of note, only 23% reported prior PrEP use. So once again, really accessing those people who would benefit most from PrEP who are not currently accessing. So similar to Purpose 1, really astounding results. Only 2 new infections occurred in the lenacapavir arm, and so that equated to an HIV incidence of 0.1 per 100 person years. This is in contrast to the background HIV incidence that was calculated of 2.37 per 100 person years. And then also the HIV incidence calculated in the FTDF arm, where 9 new infections occurred and a calculated incidence of 0.93 per 100 person years. When you look at lenacapavir versus background HIV incidence, it was 96% effective in preventing HIV in that analysis. When you compare directly versus FTDF, lenacapavir reduced HIV infections by 89%, so superior to FTDF in reducing HIV incidence. This is really incredible results. So one thing that has been noted with lenacapavir are injection site reactions, and particularly nodules that people experience when the drug's injected. Because of its subcutaneous and long-acting nature, it does form a drug depot in the skin that is palpable. You can see that in both Purpose 1 and Purpose 2, very few participants discontinued due to injection site reactions. You can also note that the majority of these injection site reactions and nodules were mild, and that they actually decreased over time, which is an interesting phenomena that's also been seen in HIV treatment trials of long-acting injectables. So while yes, nodules do occur, and in some cases pain or erythema and swelling, it tends to be mild and it tends to be reduced over time with education of people who are receiving the injection, as well as education of those who are giving the injection in proper injection delivery. So now I'd like to shift gears a little bit and talk about the intravaginal ring for pre-exposure prophylaxis. So the Depivirine ring for HIV PrEP is a ring that's placed into the vagina every month that slowly releases the antiretroviral Depivirine into the body to help prevent HIV infection. It works to prevent HIV in people who are HIV negative, who, in the same way that an oral PrEP pill will, but gives people the option that don't want to take the PrEP pill. It's a flexible silicone band that contains the drug and was developed by the International Partnership for Microbicides. So why do people like the Depivirine ring? Because this is a woman-controlled intervention, and women bear the brunt of the HIV epidemic across the globe. And so it is discreet, there are few side effects, it's easy to use, and it works well. And so this is an important intervention for women that choose not to use daily oral PrEP. The Depivirine ring does not prevent against pregnancy or other STIs, but maybe in the future we'll have a product that does. So with respect to the Depivirine ring, previous trials have shown an approximate 30% reduction in HIV risk versus placebo. It's important to note that efficacy, however, was much higher among those who had high adherence to the vaginal ring. It exceeded 50% in those people with high adherence. However, the Depivirine ring trials did not include, the efficacy trials did not include pregnant individuals. So now we have MTN 042, or the DELIVER trial, which studied the Depivirine vaginal ring for use in HIV prevention in pregnant individuals. And so this study was a phase 3B study of pregnant individuals living in Malawi, South Africa, Uganda, and Zimbabwe later in their gestation period who were interested in HIV prevention. So these were people aged 18 to 40 who were more than 30 weeks pregnant, and they were randomized 2-to-1 to the Depivirine vaginal ring, 25 milligrams monthly, or oral FTDF daily. And then they were continued on these agents until delivery or 41 and 6 days, weeks of gestation. So the primary endpoints for this study were maternal safety, infant safety, and pregnancy outcomes. And the secondary endpoints were adherence, acceptability, infant drug levels, and pregnancy complications. And so you can see in this chart, comparing the people who are randomized to the Depivirine ring versus FTDF, that overall they were quite young, in their 20s. More than half, almost 3/4, had had a prior pregnancy. Almost all went to live full-term birth. There were very few stillbirths, and there were extremely few maternal adverse events. There were some infant adverse events noted, but these were similar across the arms and not thought to be due to drug exposure. And so overall, adverse events very uncommon with use of either the Depivirine ring or FTDF in the third trimester. We also recently learned about newer formulations of the dapivirine ring that may be available someday. IPM 054 compared 3-month versus 1-month dapivirine ring, so being able to insert and keep the ring in place for a longer period of time. So this was an open label crossover randomized phase 1 trial in South Africa that was conducted among HIV negative participants assigned female sex at birth who were on effective contraception before the study started. And 124 people assigned female at birth were randomized 1-to-1 to use a dapivirine ring for 90 days, replaced every 30 days versus using it 90 days continuously. Then there was a washout period, and then people switched to the other arm, so either using 90 days continuously or replacing every 30 days. The primary endpoint was plasma dapivirine concentrations, and secondary endpoints were vaginal fluid dapivirine, safety, PK, and the vaginal microenvironment. And then, of course, exploratory endpoints, very important, perceptions and acceptability of the ring. What this saw was that the 3-month ring had plasma concentrations that were higher than those using the 1-month ring during their 90-day use period. The AUC was 55% higher. The 3-month ring also achieved 41% higher vaginal fluid concentrations than the 1-month ring, but the PK profiles in months 2 and 3 were similar. There was a residual drug seen in both rings, about 81%. The most common treatment associated adverse events were vaginal discharge, candidiasis, and bacterial vaginosis, but these were similar between the groups. So, based on this study, the 3-month rings demonstrated superior PK to the 1-month ring with only modest increases in drug exposure systemically. And so, this really underlines the need to study this 3-month ring in further trials, as there are some potential benefits to using it, meaning reduced insertion burden, improved adherence potentially, reduced cost and waste. And so, this is an exciting intervention for us to watch out for in the future. So let's think about some emerging real world data on PrEP. How is PrEP being used in practice? And so there's a couple of studies that I think are really important to be familiar with. First is an INSIGHT cohort that was looking at oral PrEP uptake and persistence in young African women. This study is important because adherence in the clinical trials among young women in Africa has overall limited our ability to see efficacy of oral PrEP. In those clinical trials. And so it's really been a bit of a conundrum to understand whether young African women want to use oral PrEP. And so this study tells us that they do. And so this was 3,087 women aged 16 to 30 years who'd been sexually active in the previous 3 months who were interested in taking PrEP. This is 20 sites across Africa in Eswatini, Kenya, Malawi, South Africa, Uganda, and Zambia. Participants were tested for HIV and STIs, and then they completed demographics, HIV testing, sexual behavior questionnaires. Everyone was offered FTDF at PrEP enrollment at enrollment, and then at each follow-up visit at months 1, 3, and 6. And so participants got HIV testing, risk reduction, and adherence counseling throughout the study. And then to understand adherence, a point-of-care urine tenofovir assay and acceptability questionnaire was performed. And so across the INSIGHT cohort, which was amazing, they saw high PrEP uptake greater than 90%. They also saw high PrEP persistence through 6 months, which was really exciting to see given what had been seen in prior clinical trials. More than 90% received refills at each of the visits. Overall adherence was high, 65 to 72%, based on point-of-care urine tenofovir assay. HIV incidence was still 1.4%, but this is lower than one might expect in a similar population and also similar to the 1.8 HIV incidence seen in the FTDF arm of HPTN 084. And so on the right side of this, you can see over time changes that occurred in PrEP refills, as well as urine tenofovir positivity over time being fairly stable, ranging from 72% at month 1 to 65% at month 6. Another study that was just recently presented at the CROI conference is looking at on-demand or the potential for 211 oral PrEP among cisgender women, and this is for FTDF. And so this study showed that based on PK/PD modeling, that cisgender women, if they were to use on-demand PrEP around the time of sex, may need an extra dose. So instead of 211, it might be reasonable to consider 2111 for cisgender women, or some other formulation similar to that, maybe taking 2 pills on multiple days instead of 1. So the key takeaways was that any 4-day regimen provided more than 80% coverage for the 7 days of around the time of exposure that we anticipate people would need for an on-demand regimen. And if 2 doses were taken for those 4 days, this provided greater than 94% coverage of drug for the 7-day interval. Another real world PrEP study that's important is the SEARCH trial. And I love this study because it's about dynamic choice for HIV prevention and really shows us how if we give people choices, we can increase PrEP uptake across the board. So in this study conducted in Kenya and Uganda, investigators looked at the proportion of time covered by any medical HIV prevention intervention, either with standard of care and the choice of prevention product, including post-exposure prophylaxis, oral PrEP, or long-acting cabotegravir. PEP and oral PrEP are provided in the control group as standard of care. And so this was really to see if you give people the option of injectables, will you get greater PrEP uptake and adherence? This was an extension of 3 randomized controlled clinical trials. So in the first phase, very importantly, they showed a 30 to 40% increase in prevention coverage with the DCP intervention, which is person-centered care, structured choice of prevention product, and the ability to change over time versus the standard of care, which is just providing medications, PEP or PrEP. In the LA CAB extension, super exciting, a 56% increase in prevention coverage with the intervention versus standard of care. The SEARCH trial showed having a choice increased PrEP use. So when long-acting cabotegravir was introduced, it did not just replace oral PrEP, but actually attracted new users. Of those who initiated long-acting cab in the study, 43% had not been using any PrEP in the previous month, despite availability of the oral products. And so once again, dynamic choice didn't just shift people over to long-acting cab, it increased new users on pre-exposure prophylaxis, which is really what we need to do to end the HIV epidemic. So over the course of the trial, about 56% of people chose long-acting cab, 53% chose oral product, oral pre-exposure prophylaxis, and 2% used PEP. There were only 7 incident HIV infections in the standard of care group and 0 incident HIV infections in the intervention group. So really, really outstanding. So where are we going in the future for PrEP? Let's review that a bit. So the Ending the HIV Epidemic in the US has goals that we are to reach by 2030. And the goals of the EHE program is to reduce new HIV infections by 75% by 2025, the current year that we're in, or by 90% by 2030. And the goals of the EHE are to advance health equity by scaling up key HIV prevention and treatment strategies. And so obviously PrEP plays a very important role in the EHE initiative. We have made some progress in ending the HIV epidemic. New HIV infections have actually decreased 12% from 2018 to 2022. But clearly, we're not at that 75% goal of 2025, and we have a ways to go to reach that 90% goal by 2030. However, we have the tools to do this. If we diagnose all people with HIV as early as possible, if we treat all people with HIV and sustain viral suppression in those, U equals U. If we prevent new HIV transmissions by using proven interventions, and if we can respond quickly to the potential HIV outbreaks to get prevention and treatment services to people who need them, those are the 4 pillars of the EHE epidemic. And if we're able to implement those widely and broadly and equitably, we will progress to reach our goals of the EHE epidemic. So, how do new prevention projects fit into the EHE plans? So, as I just talked about in the search study, increasing choice for people will increase the probability that they will use PrEP. And so, giving people more products to choose from for HIV prevention will mean more people on PrEP. And that's what we need to see. There are all kinds of new products in preclinical and clinical development for pre exposure prophylaxis. This includes implants, vaccines, multi purpose vaginal rings that do more than just prevent HIV, medicated douches, patches, gels for the vagina, films for the vagina, monthly oral pills, broadly neutralizing antibodies, other injectables, and inserts. And it's really exciting to think about what this pipeline looks like. There are others where efficacy trials are underway, new daily oral PrEP products, new combination oral PrEP and contraceptive products. Those trials are in development. We are anticipating that the FDA will review and hopefully approve lenacapavir in June of 2025. And so hopefully in just a few months, injectable lenacapavir every 6 months will be part of our prevention toolbox. And then, of course, we already have the dapivirine ring and injectable cabotegravir that have been approved in the last few years, in addition to daily oral products and on-demand products for people assigned male at birth. So, just to review those PrEP products again that are in preclinical and clinical development. So, we have long acting oral agents that could provide prevention protection with less than daily adherence. And so, this is important. There is a product, MK8527, that is a monthly pill that's in development. Longer acting injectables, I'll show you some data from promising PK about something that's even longer than every 6 months. Broadly neutralizing antibodies are under study, and these are important because these are not antiretrovirals and would not be used necessarily to treat people with HIV infection after they seroconvert. And so, this is a really attractive way of preventing HIV infection that's under study. I mentioned multi-purpose vaginal rings that maybe could also prevent pregnancy or other sexually transmitted infections in a single product, in addition to prevention of HIV. Vaccines, of course, the holy grail in HIV prevention, aiming to provide lifelong or at least long term HIV prevention by stimulating an immune response. We're a long way off from an HIV vaccine, but so much progress has been made that there is hope for one in the future. And then all of these products are being studied with innovative delivery methods, including injectables, vaginal gels, films, patches, douches, etc., that are formulating antiretrovirals in different ways that may be more acceptable for people to use. And so, efficacy trials that are being planned and are underway include daily and monthly oral agents, as well as I mentioned the combination oral contraceptive with oral PrEP pill trial that is being planned. And so, those may be available to us sooner than some of the other products I mentioned. And it's really exciting to think about that as being part of our toolbox in the near future. So, just to go in a little bit more depth on the new long acting oral NRTTI, also currently known as MK8527, that's being studied for PrEP. So, this drug is in the same pharmaceutical class as islatravir, a new class of antiretrovirals called oral nucleoside reverse transcriptase translocation inhibitors. It's different in chemical structure from islatravir, but is part of that class of medications, the NRTTIs. This is being investigated for once monthly oral dosing for PrEP. Once weekly dosing is what's being studied for HIV treatment. And so these are phase 1 trials that have been completed that evaluated ascending single doses and ascending multiple doses in adults without HIV. They showed that the drug was well tolerated and the safety and PK profiles supported phase 2 investigation. So, phase 2 trials are underway, also assessing safety, tolerability, and PK of once monthly dosing in adults at low risk of HIV acquisition. And so, 3 doses are being explored: 3 milligrams, 6 milligrams, and 12 milligrams for the Q-month regimen in those phase 2 trials. And we hope to see this medication in efficacy trials one day soon. So, another exciting option is that dual prevention pill that I mentioned that includes both an oral contraceptive as well as FTDF for HIV pre exposure prophylaxis. So, this is a multi purpose prevention technology or an MPT. Efficacy, it's unclear yet if efficacy trials will be required. It's not likely that they will, since each drug individually has already been studied and is FDA approved. And so it's likely that the drug maker will need bioequivalency data of the two approved drugs, FTDF and the hormones that are being used for contraception, ethinyl estradiol and levonorgestrel. And so bioequivalency will be calculated for those when they're dosed together, and we're hopeful that that will be acceptable for FDA approval. This is a 28-day regimen, so it's 21 days of PrEP and the oral contraceptive pill, and then 7 days of PrEP only pill, similar to how one might take oral contraceptives currently. So that is all I have for you today. So just to review what we've talked about, PrEP is highly effective for HIV prevention, yet it's often underutilized. We are not reaching everyone who could benefit from PrEP. And so as we do more, as we have more options, as we have more products that people want to choose from, we hope we see an increased utilization of PrEP. Currently available PrEP options in the United States include daily oral combination pills, FTDF and FTAF, and an every 2-month long-acting injectable cabotegravir is what's been approved so far. We are anticipating FDA review of long-acting injectable lenacapavir every 6 months in June of 2025. There is available the intravaginal ring, dapivirine, that I told you about. It is not going to be available in the United States, but it is available in certain African countries in demonstration projects, and hope to see that more widely available soon. Overall, reducing barriers to PrEP access and adherence and ensuring diverse populations are represented in PrEP clinical trials is really critical to achieving ending the HIV epidemic goals. And I reviewed at the end there future PrEP options, which are so exciting to think about: combination therapies, PrEP and oral contraceptives, or maybe even something that prevents sexually transmitted infections, longer acting oral agents, additional intravaginal agents, injectable options, self-administered injections, implants, and BNABs are all in the pipeline and all being studied for their efficacy in HIV prevention.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This program has been supported by an independent educational grant from Gilead Sciences, Incorporated. To access all materials for this activity, visit peerview.com/NQE860.